isn't, and more or which is less. But this is the topic about which one can discuss or what one can continue discussing it for hours and hours. There are various aspects of polycystic ovarian syndrome which can be discussed. But recently I came across a write-up which is latest, which was of this year, that is 23, and which I thought was quite concise and conveyed all the essential information related to polycystic ovarian syndrome in a comparatively concise manner. And that is what I would want to take you along with in the next about 30 or 35 slides. I previously have had, over the last 20 years, about 10 various presentations about polycystic ovarian syndrome. One which I made about 2 or 3 years ago that emphasized certain other aspects. But this is the one that I think serves the purpose for postgraduate students and gives them food for thought on which they can build up their own. And I would strongly suggest to you that you take this presentation as a template on which you build up the various aspects for your own self. You make your notes, you look at the various aspects of its from starting from its definition, its history, geology, that with the history that started in 1933-34 by Stein Leventhal, because when I was undergraduate and even a postgraduate, it used to be called Stein Leventhal syndrome. That was in mid to late 70s. And when I became assistant professor, then 81 after that, it became polycystic ovaries disease and syndrome, etc. So we'll get on with it. Right. This is an endocrine and metabolic condition. Endocrinological condition, because there are disturbances of endocrine or hormone productions and the resulting effects of those. The incidence is variable. It's quoted from 5 to 20%, 5 to 10% generally, but in this write-up, it is 20%, to which I actually agree, because these days you come across so many girls, and mind you, please don't stop anyone from eating chicken or broiler, etc. Don't go into that kind of thing. That's not really got anything to do with that until and unless it is proven or there are studies about that. So, but I generally quote to the girls who come with this to say that 1 in 5 girls have some degree of polycystic ovarian situation. I don't even call it a syndrome or a disease, so that they are not kind of get frightened of this. So I say that something which is prevalent in 1/5 of population cannot be a disease or something, and it is a variant of a normal, and you are okay, you are normal. That kind of reassurance. We know within our profession, when we discuss professionally, that it is a syndrome, it is a problem, and it has multiple implications. But when we talk to the patients, then we have to soften our tone, we have to soften the kind of negative information, so that it does not make that kind of adverse impression on the patients. And its etiology, we do not know why it happens. There are many factors which are involved, and those are multifactorial. But one thing now is important, that this is characterized by 3 various things, which is excess of manifestations of excess of androgens, which may be clinical, which may be biochemical, and also it is accompanied with the dysfunction of the ovulation. So there is infrequent ovulation, which obviously then affects menstrual cycles. Sometimes there are the bleeding is long, sometimes there are periods of amenorrhea, oligomenorrhea, etc. and polycystic ovarian morphology, which is seen on ultrasound. Initially, this particular third one was not given that kind of importance. But since the use of vaginal ultrasound so widely, and also the assessment of ovarian morphology or ovarian appearance on ultrasound, this has become handy. So we need to remember that these are the three things which are related with this. And then hyperandrogenism, as I said, would have clinical manifestations like male pattern of hair growth, acne, alopecia. We do not come across alopecia as such so often, but many of the girls would complain of excessive hair fall, and modified assessment on Ferriman-Galvey score, and a score of 4 or greater would show that there is hirsutism. And biochemical hyperandrogenism is shown in the form of higher levels of free or total testosterone and dehydroepiandrosterone sulfate. Second is ovulatory dysfunction, menstrual issues, as I said, amenorrhea, when there is no ovulation, or irregular menstrual cycles, missed or delayed, and irregular cycles shorter than 21 days or longer than 35 days. And if sometimes there is continuous bleeding for prolonged periods of time, but typically this bleeding is, anovulatory bleeding is painless, usually. That is the characteristic of anovulatory bleeding. Now that bleeding can be in the form of spotting, or it can be heavy bleeding. And if sometimes if it follows a period of amenorrhea, during which time there has been an occasion for endometrium to grow and to become thicker, when that is shed off, obviously that will result in heavy blood flow. So therefore, the pattern of bleeding can be completely abnormal and completely be haywire. And then, of course, those who are married and they want to have children, they would present with infertility. But I'm sure that all of you who have worked in obs-gynae for some time would come across patients in their mid-30s who have had 3-4 children and who completed their family. And at that age, they for the first time present with features suggestive of polycystic ovarian syndrome. And when you look at the various aspects of that, various characteristics, you would make a diagnosis of that. The third one is polycystic ovarian morphology, which is seen on ultrasound. And now, as I said earlier, that this has become more obvious on vaginal ultrasound. And previously, you are going to shortly see a slide which I prepared 2 years ago, and in that I had given this figure of 12 antral follicles, but now they define it as more than or equal to 20 antral follicles per ovary, etc. But for my, this is what now the guidelines say. And you should go according to the guidelines. But I will also continue to tell you about my experience. And I just this morning was wondering that if I had accumulated, I still have the record of all my patients whom I have treated in my private practice. And that's a fairly comprehensive report. If I collect that, I think I can publish, because my experience in a couple of particular areas is different from what this presentation would show. But this presentation, since it is an academic one, and this is something that you would be talking about in conferences or in examinations or in academic areas, and something which is not published cannot be quoted. So I can continue to practice what I think is giving me better results in my patients, but I cannot really teach that. So the antral follicles now 20, but I start treating women as PCO patients if they have follicles 12 to 14 antral follicles on vaginal ultrasound. I start treating them as PCO. General considerations about polycystic ovarian syndrome. These are known 7 risks for long-term health issues: infertility, insulin resistance, obesity, cardiovascular disease, metabolic syndrome, obstructive sleep apnea, and mood disorders. But this is important that there are conditions which also present with features which are suggested generally as we see more cases of polycystic ovaries. So we intend to label them as polycystic ovaries, but there may be those are uncommon, but they are there are other conditions which are not essentially because of polycystic ovarian syndrome. We will talk about that also. And management of polycystic ovarian syndrome varies during various phases of reproductive life. This is important to inform the patient, or if it's in the case of a young girl, the mother also. In cases of teens, we have a different approach, or in those girls who are unmarried, the approach is different. But when they are married and they are keen for having a pregnancy, the treatment would be different. And those who have completed their family, the approach for them, the treatment would be slightly different. For example, in the teens, you might tend to, and you would mostly prescribe oral contraceptive pill. For those who are married, the treatment would be different. And those who have completed their family, if they are younger than 40, you can continue with oral contraceptive pill if there is no contraindication as such. But those who are above 40 years of age, I personally do not recommend or would not really favor contraceptive tablets containing any amount of estrogen, like 30 micrograms and more than that, because of increased incidence of thromboembolism. So lifestyle modifications are important to manage. That is for all, and pharmacological treatment for specific symptoms as the presentation goes on. Now, the accepted definition of PCOS, certainly there is one which is just written in the second component of this slide, which is Rotterdam criteria of 2003. That triad of features, which is hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology. If any two of these are present, then you can say that polycystic ovarian syndrome is there. And the most recent guidelines, these international endorse the use of the Rotterdam criteria for establishing diagnosis of polycystic. I'll tell you a little bit about this. This is a slide from one of my previous presentations. The national, but these are still quoted. Yes, what do you want to say? Please, someone raise hand. Okay, so National Institute of Health in 1990, they only said oligomenorrhea or amenorrhea, which is ovulatory dysfunction, and clinical or laboratory evidence of hyperandrogenism. Now, you see in those, the clinical or laboratory, that is there, but ovarian morphology doesn't fare anywhere. At that time, vaginal ultrasound was not really so common. Rotterdam in 2003, any two of three criteria, oligomenorrhea, ovulatory dysfunction, hyperandrogenism, and PCOM, polycystic ovarian morphology. And 2006, Androgen Access Society, presence of the same features. But this is the one that we are concerned with. This is still universally accepted to be that any two of these three features would be part of this. And requirement of that, I told you that this was a slide which was made 2-3 years ago. And in that, ovarian morphology consists of more than 12 follicles between 2 and 9 millimeters in diameter, and in at least one ovary, or an ovarian volume of more than 10 milliliters. And now, of course, the current guidelines say 20 or more. But in practice, I still emphasize that I'll go along with more than 12. Now, this is these are the different 4 phenotypes. Phenotype A is in which all these 3 are present, which is hyperandrogenism, ovulatory dysfunction, and polycystic ovaries. Phenotype B is in which 2 of the first ones, ovulatory dysfunction, hyperandrogenism. Phenotype 3 in which the second and third, and phenotype D in which 1 and 3 are present. Other causes of menstrual irregularities or hyperandrogenism, which we need to exclude, as I said earlier. One is non-classical congenital adrenal hyperplasia, which is because of deficiency of 21-hydroxylase. And that can also lead to higher levels of androgens and hirsutism, menstrual abnormality. And when there is, of course, higher levels of androgens, there will be, but the picture is more or less classically like that. So this is important that we need to look at that. Thyroid abnormalities and elevated levels of serum prolactin, that needs to be done. And androgen secreting adrenal tumors, they are unusual, uncommon, but whenever they are there, but in those cases, the serum androgen levels are of a high level, one, and secondly, the onset of symptoms is rather acute. This is a schematic diagram which is given about overview of diagnostic lab testings to establish or exclude polycystic ovarian disease. That if there is hirsutism, you look at medications. If she has taken any of those, yes, discontinue medication, and then yes, or if persistent symptoms, then go on. If no, then go on. Irregular menstrual cycle, screen for pregnancy and reproductive age. That's, of course, is the first thing that we need to look at. If positive, of course, then we know what to do. If not pregnant, then yeah. Acanthosis or central obesity. आप अपने सवाल सारे लिख लेना एंड में मुझे बता देना, फिर मैं देख लूंगा. Evaluate for metabolic syndrome, identify additional signs of PCOS, development of hirsutism, and then discontinue medication, and then receive positive or ये फिर biochemical testing है. Now, TSH, both hyper and hypothyroidism can mimic symptoms of PCOS. Prolactin values more than 25 milligram per deciliter suggest hyperprolactinemia and require evaluation. Dehydroepiandrosterone sulfate values more than 700 micrograms are concerning for a virilizing tumor. 17 hydroxyprogesterone is a typographical mistake. Hydroxyprogesterone values more than 2 to 4 milligrams per ml measured during the follicular phase should prompt additional evaluation for non-classical congenital adrenal hyperplasia. Cortisol elevated levels suggest Cushing syndrome and cortisol resistance. And insulin growth factor, insulin-like growth factor 1, elevated levels suggest acromegaly. And this is the total one. This is available on that write-up. I can share it with you. Pathogenesis, how does it happen? Multifactorial, we do not really know what actually causes that. A genetic basis, now that is unraveling, that is coming up, and we would maybe in next 5 years, we would find those essential genes which are responsible for that. And genomic genome-wide association studies have identified 19 specific loci associated with PCOS. However, these 19 account for less than 10% of PS hereditability. Role of environmental factors or impact as early as in utero continue throughout individual's life. Geography, nutrition, socioeconomic status, and toxin exposure. Socioeconomic status is also there, important. Was examined in one study carried out in 2011. And then endocrine disrupting chemicals. Now there are news about forever chemicals, which are known as per or chloroalanine substances, PFAS. Those are substances which are found in plastics, in paints and varnishes and all those things which we use commonly, and they are called as forever chemicals, or chloroalanine substances. Yes. So those are also implicated in, and one which has been mentioned in this, that is bisphenol A, compound found in consumer plastic products. Then polycystic phenotypes differ in women of various races, and they've seen that South Asian women or Indian origin women, even in America, they have greater incidence of polycystic ovarian syndrome. Now, what are the metabolic consequences of polycystic ovarian? We have talked about pathogenesis. These are 7, as I earlier said. Insulin resistance, one of the most remarkable risks. Obesity is highly associated with PCOS, and at one time it used to be said that 50% of women presenting with PCOS symptoms are overweight, 25% are underweight, and 25% are normal weight. But mostly we see that women have heavier weight. And then dyslipidemia, one of the key adverse effects of polycystic ovarian disease. It's important from their future well-being and future health. Polycystic ovarian syndrome and the cardiovascular disease, endometrial hyperplasia, of course, from our point of view, from pharmacological point of view, it's a risk for developing endometrial carcinoma, and mental health disorders and eating disorders. Now we can take them up in detail. I will not really go into a lot of detail about this, but insulin resistance risk is threefold more compared to the general population, compared to those women who do not have polycystic ovarian disease. Early onset glucose intolerance is present in 30 to 40% women who have polycystic ovarian syndrome. And similarly, early onset type 2 diabetes in 10%. If they are obese, the risks are enhanced. And therefore, it is recommended that insulin resistance screening should be carried out when polycystic ovarian syndrome is diagnosed, and then thereafter every 1 to 3 years. These are difficult to follow, but these are some of the recommendations, and you can identify which one to carry out. The bottom line is that there is insulin resistance, and the consequences of that, of course, one is early development, one is glucose intolerance, and second is early onset of type 2 diabetes. Thirdly, it is the risks are enhanced if the woman is overweight. And how can we identify those? By oral glucose tolerance test, or as it is said, fasting plasma glucose level or hemoglobin A1C levels. But oral glucose tolerance test is recommended in high-risk women who have BMI more than 25. And also, this is important, that this is normally we do oral glucose tolerance test in pregnancy between 24 and 28 weeks. But if a polycystic ovary syndrome girl is pregnant and presents in pregnancy, then and we do not know her glucose status, then it is recommended even before 20 weeks, so that preemptive measures can be taken. Just this morning, Rubina has sent me this primordial prevention, a futuristic approach to intervene in gestational diabetes and its sequelae, which means that you diagnose it earlier, even before it starts showing it. So therefore, in these are important information, then it is not really difficult to remember, although they seem to be many points about this, but it is important that this is what we do in our approach. Obesity is, as we know, that it is associated with that, and it increases the features of polycystic ovarian syndrome and its consequences like infertility and insulin resistance. A risk factor for obstructive sleep apnea, and obstructive sleep apnea rates have been found to be 5 to 10-fold higher in patients who are obese and have polycystic ovary syndrome. Dyslipidemia, one of the key adverse factors, prevalence up to 70%, which is very high. Patients need complete fasting lipid panel as a screening tool. Obesity, women with obesity associated with elevated levels of total cholesterol, risk for metabolic syndrome as well as cardiovascular disease. So far as there is no clear inconclusive association, but increased coronary artery. No, it is actually, yeah, you're right. No, yeah, Asians के लिए 30 नहीं है, उन्होंने वो मैंने इसमें कम कर दिया था. Asians के लिए और South Asians के लिए particularly, it is not 25 or more, it is 23 BMI. Actually, I deleted that for simplicity's sake. So it is not more, it is less. And if we for Asians, it is 23 BMI, at which one would start investigating. Increased coronary artery aortic calcification worsens with age, leading to premature atherosclerosis and subclinical vascular disease. Recommended screening guidelines for CVD in women with measurement of height, weight, BMI every 6 to 12 months, so that you keep a watch on the weight and also blood pressure. Women with should be considered at risk of if they have any additional factors like obesity, use of tobacco, dyslipidemia, hypertension, etc., or lack of physical activity. If these are there, then they are at greater risk. So this is actually something that we need to educate women about. Dyslipidemia, we identify also, we carry out the relevant investigations, and also inform that if you do not control your weight and if you do not adopt healthy lifestyles, then these consequences are likely to be there, which may would have appeared, say, at the age of 50, might start appearing at the age of 30, or so on, and also increase in their endometrial hyperplasia. This is important because you see, it is quite simple to understand that in those women who have oligomenorrhea or amenorrhea, then there is prolonged exposure of endometrium to estrogen, because there is a large number of small follicles which are continuing to secrete estrogen, and the level of estrogen is a little higher. That leads to that lack of periods, and that also in most of the women leads to endometrial hyperplasia. And that hyperplasia ultimately is likely to develop into endometrial atypia, etc., and also endometrial carcinoma. So unsuppressed estrogen, because then there is no counteracting progesterone. And women are at least 3 times more likely to develop endometrial cancer. Screening endometrial cancer is not recommended until and unless there are features which suggest those. Low threshold for evaluation of amenorrhea or abnormal vaginal bleeding. Consider ultrasound or endometrial biopsy. No official recommendation for optimal prevention of endometrial hyperplasia. And 2018 guidelines suggest treatment with combined oral contraceptive pill for or progesterone if cycles last more than 90 days. If there is 3 months, there is no periods, which would mean that if there are no periods, there are 4 or less number of periods in a year, then I generally would start not really 90 days. I would start at 45 days. My general recommendation is that I would give dydrogesterone 10 milligrams PD for 5 days after, if the periods are overdue by 2 weeks, which is 45 days. So if the period overdue, that's good for the woman's psyche as well as for the endometrial health. So mental health disorders, it is not actually surprising that these girls would have mental health issues, or no, mental actually do not fare so prominently in our consideration generally, because we are too concerned with physical issues that psychological considerations don't really matter at that time, and we are probably in a hurry to deal with our patients. And mental issues, psychological issues, they require time, discussion, and a sympathetic approach. Dydrogesterone, defestone, 10 milligrams twice a day for 5 days, every 6 weeks. So that's why they go unnoticed. And but this is large number, 40% of women with PCO, which means that 8% of their incidence is. If the incidence of, let's say, that's on the higher side, if incidence is 20% of girls have polycystic ovaries, and out of those 40% have mental issues, which would mean 8% of the total population of girls, which is large. And of course, the reason for that is that they have a lower self-esteem of themselves because of obesity, hirsutism, and other changes in physical appearance. Which is not very difficult to understand. And therefore, we need to be sympathetic, empathetic, not sympathetic, empathetic. Sympathetic means that we are kind of looking down upon them. Empathetic is that we are at the same level. We are dealing with them, sitting on the same level. And therefore, we need to convey to them that we do understand that they have this issue. And this is something which is, we need to help them reconcile with these and give them hope of improvement and how they can overcome these appearance issues, etc. Eating disorders have an increased prevalence, and if suspected, then appropriate specialists should be referred to. Management. Lifestyle modifications. The objective is in that lifestyle modification is lowering the risk of metabolic consequences, by which you mean that you control the weight of them, you help them control the weight and also look after their blood pressure, etc. So nutrition, well-balanced means exercise and behavioral strategies. These are important and they would require time and discussion with them, because behavioral strategies will also help them achieve their nutritional and exercise targets. Now, for weight, of course, reduced caloric intake, which is up to 30% of the one that they are taking. So generally, in most of our population, it is not possible for us to calculate, and many of them would say, "Kiji, aap diet chart." Now, those diet charts are, I personally feel they are worthless. They have been adopted by from the Westerns, where they have those measuring cups and they will take so many grams, so many milliliters, etc. And we do not in our kitchens. Even in modern kitchens, they may have those measures, but we do not really know. Kiji, ye roti jo hai, uska वो पेड़ा बनता है वो कितना ग्राम का होगा, वो तोलेगा पहले उसको पेड़े को, फिर उसकी रोटी पतली बनेगी कि क्या होगी कि किस तरह से. सो मैं तो उनको लड़कियों को उस तरह से कहता हूँ कि जी बात ये है कि मेरी रिकमेंडेशन ये है कि आप आधी रोटी चटनी के साथ सुबह खाएं और आधी रोटी चटनी के साथ शाम को खाएं. और साथ ही मैं ये कह देता हूँ कि दिस इज नॉट पॉसिबल, ये होगा नहीं, लेकिन जितना किसके करीब हो सकते हो तो वो करें. कहने का मतलब ये है कि आपने वो उस तरह से करना है. But we all have to adopt our own methodology of conveying this important information to them, that they have to reduce their caloric intake. और उसमें यह है कि आप when in those women like those who have gestational diabetes, you tell them at 24, 26 weeks they have been diagnosed to have gestational diabetes, and you find that their glucose levels are high, and you tell them that you be careful about your diet, you take this and you do not take that. And then you have to be specific that not even fruits, because the impression may be that if they take fruit, that is not considered. So you have to tell them specifically, no cold drinks, no Coke, 7-Up, etc. And even, of course, very starchy things. So we have to be, overall, we can't really give that so many grams, so many items or whatever, but generally that these are the things to be avoided, so that our sense of satiety should never be really achieved, in which you feel that you're overeaten, that should not be there. And then second point in that is consistent medium or high intensity exercise. Now this 75 to 150 minutes walk per week, ये जो 75 not walk है, it is the high intensity exercise. आजकल ये है HIIT उसको बोलते हैं, high intensity interval exercise, which means that you do that for 2 minutes. For example, if you are jogging on a treadmill, then for 2 minutes you jog at the highest speed that you can attain, and then you come back to the normal that thing. That is known as high intensity interval exercise, and that has greater effect on the beneficial effect than consistently less intensity exercise. So, but 75 to 150 minutes of high intensity exercise. But someone who is overweight, for them to ask to run or skip a row, that is not practically correct, and that is not something that will be achieved. So the goals should be achievable, they should be practical. And so I generally tell them to start a walk in the park, and start with, say, 15 minutes a day. and the speed should be such that they do not get out of breath. A speed at which you can converse. And then this should be incremental. Every week you add 5 minutes to that. Next week it'll be 20 minutes, so that ultimately you attain a time period of 45 minutes of walk. And then you start also with the time, you also start increasing your pace. So it is a little more brisk than the previous speed. So you increase the time, you increase the pace. And that's how you gradually achieve a certain level. And that's for individually for each person at their own pace and at their own comfort level. Then behavioral strategies of goal setting help them differentiate between PCOS and by patient is how much to lose. No, not really. You can't really give. Remember, tell them that if they start dieting, they start the exercise for first 2 months, nothing will happen, because in first 2 months, if they, after 2 months they weigh themselves, they will weigh more or less the same. So warn them that initially for 1 or 2 months, it's not going to make a lot of difference. And if they are they are not forewarned, then they'll get very upset about it. So tell them this. ये वेट का अगर आप देखो तो नीचे वाला जो है उसमें important है step वो कि we are talking about actually behavioral strategies, but in women with PCOS who are overweight or obese, even a 5% to 10% weight loss significantly improves metabolic and fertility outcome. 5 to 10%. So what I tell as someone who is weighing 210 pounds, I tell them you don't have to be 150 pounds to achieve a pregnancy. She can have a pregnancy even at 210 pounds if I mean everything favors her. But if she reduces her weight by 10 or 15 pounds, she doesn't has to come back to 150, which is probably would be the normal, or 140. But if she just loses 10, 15 pounds, even that's going to make a lot of difference. And because that would show a trend, and that also will encourage her to continue to adopt those attitudes, those strategies which have helped her achieve that target or achieve that reduction in weight. So that is something which is needed to be cheered about, which is needed to be congratulated about, and encourage them to continue with that. So there isn't any set point in weight, but as I said, 5 to 10% that helps, and not that it should only be 5 to 10%, but continue. Ask them to continue with that. And now, you know, the understanding about the weight, etc., or obesity, the concepts are changing. Number one, these days it is not appropriate to call someone obese. And the term now is a person who has obesity, who has problems with weight, or who has weight issues. So that kind of thing. But what is meant here is that we need to help them in that. So behavioral strategies, again, in goal setting and self-monitoring, can be useful in weight management and overall well-being in women with PCOS. So this is, and actually, I think this is an important slide for management of PCO. And we need to emphasize to each of the women, we need to formulate our 4, 5, or 10 sentences, whatever we have. And we keep repeating those 5, 10 sentences to each of those polycystic PCOS patients who are overweight, and so that we kind of memorize them, and that becomes in our reflexes, and then we also kind of would cover all the various important aspects. Pharmacological treatment. Contraceptive pill is a very useful preparation, you know, in the specialty of gynecology, because it has so many non-contraceptive benefits, like menstrual abnormalities, whether they are because of polycystic ovaries or otherwise. So combined pills are combined hormonal contraceptive. Some would say CHC, or some would say COP, combined COP, COCP. CBC. So these can be by any method, but in Pakistan we have comparatively limited options even for oral contraceptives. So no preferred specific formulation, but generally we should avoid norethistyrone or norethindrone as it is called in USA, because norethistyrone is an androgenic derivative. It is a progesterone when we give only progestrogens, which is primolidine. That's the norethistyrone. It is an androgenic derivative, and therefore a more natural progesterone like dydrogesterone would probably be better indicated in cases of polycystic ovaries. And follow the standard guidelines for contraindication to combine hormonal contraceptive pills. Those who are anovulatory and are not candidates because of, say, they have a high blood pressure, or they're too obese, in which you would want to avoid estrogens. But essentially, weight is not really a contraindication until unless they have a very sedentary lifestyle and there is an increased reason for suspecting thromboembolic possibility. So otherwise, progestogen to prevent endometrial hyperplasia and malignancy. Now, this can be given in various ways. You can give it for 21 days. You can give for 10 days from day 16 to 25. In every cycle, you give a preparation of progesterone, even primolidine, you can give from day 16 to 10, 1 tablet, 2 tablets for 10 days. So you tell them that the first day of the periods is the first day, and counting from that, you start these tablets from the 16th day and continue for 10 days. So for 20, after 3 to 4 days, they'll have periods. So that'll make a cycle of 28 days. Or Marina to maintain a thin endometrial lining to avoid that. And cyclic oral progesterone. There used to be a mini pill, which was progesterone only pill available in some family planning centers, but that is not available anymore in Pakistan now. But we have a few preparations of progesterone available, which we can prescribe. I personally prescribe oral contraceptive pills to unmarried girls after the age of 18, not before the age of 18. If there are menstrual issues which require pharmacological therapy, how to take progesterone, but it is to be taken from day 16 to day 25, 10 days. That's 10 days, 1 tablet, one daily, or 1 to 2 tablets. So if they have regular periods, good periods with 1 tablet only, that's okay. If it's required to maintain their cycle, or if there is intervening spotting, then you can increase the dose to 2 tablets a day, one tablet twice a day. Generally, if initially you give 2 tablets a day for 10 days, day 16 to 25, and after 2 or 3 cycles, you can switch them over to 1 tablet, and that would generally be enough. Or cyclical oral progesterone, there are various ways of doing that. And if oral hirsutism symptoms do not, now for hirsutism improvement, generally we gave that preparation diane 35, which has estrogen, ethinyl estradiol, 30 micrograms, and it also has दूसरी क्या चीज है किसी को मैंने ध्यान से निकल ली थी जो किसी को याद आ रही है जो दूसरी है वो
सिप्रोटिरॉन एसीटेट होता है सर दूसरे वाला
सिप्रोटिरॉन एसीटेट so सिप्रोटिरॉन एसीटेट 2 मिलीग्राम सिप्रोटिरॉन एसीटेट की अदरवाइज प्रिपरेशन मिलती है जो अगर सिर्फ आप सिप्रोटिरॉन एसीटेट देनी हो तो वो 50 मिलीग्राम की मिलती है तो सिप्रोटिरॉन एसीटेट जो है वो डायन में है 2 milligrams, and that is very effective against hirsutism, but it takes 6 to 7 months, but that's of no consequence. I have seen girls who literally have beards, and they were cured of this. Those hair disappeared after 7 to 8 months. So, but spironolactone, I personally do not have any experience of using spironolactone, but it is mentioned here. We'll go on with this. This is treatment strategies for PCOS. ये सारी बातें जो आई हुई हैं। आगे हम जरा चलते हैं, हम जरा जल्दी pharmacological treatment, polycystic, developing insulin resistance, lifestyle modification, metformin. Metformin, 500 milligram daily, taper to, not taper to, but increase to actually hona chahiye, and gradually increase to 1,000. That's a little too much. But I have seen in my personal experience, काफी सारे, मेरा हाल है hundreds of patients में 500 milligrams twice a day, but I give them only for those who are trying to achieve a pregnancy. But in many, it would help reduce weight also. It does. I am not very fond of inositol. Absolutely not. I have never prescribed inositol. Although this particular write-up does say that there is an emerging evidence for its use in women with PCOS and insulin resistance, but it is still considered experimental. Whereas over the last 5 years, पाकिस्तानियों ने इतनी inositol इस्तेमाल किया कि हमने उसके स्टॉक खत्म कर दिए मेरा हाल. And glucagon-like peptide 1 agonists have become increasingly popular for promoting weight loss. अब weight loss की तो और बहुत सारी आ गई हैं, लेकिन ये अभी नहीं है. अभी तक मैंने इसीलिए दरमियान में स्पेस दिया है metformin तक ही रखें. So those women who are at risk of developing insulin resistance, in addition to lifestyle modifications, they also are good candidates for metformin prescription. Infertility के मैनेजमेंट के लिए इस प्रेजेंटेशन और जनरल लिटरेचर लेट्रोजोल को कहते हैं. मैं तो लेट्रोजोल को इतना नहीं लिखता, मैं तो क्लोमिफेन सिट्रेट और जनरली क्लोमिफेन सिट्रेट with metformin gives very good results. I start them with folic acid and metformin, glucophage 500 milligram twice a day after meals. And in the subsequent cycle, I ask them to have clomiphene citrate 50 milligram twice a day from cycle day 2 to 6. And the majority of them, if they do not have any other problem, not all, of course, the majority of them, they achieve a pregnancy. But literature says, international literature says that letrozole is superior to clomiphene citrate. Particularly, this study came in 2014 in New England Journal of Medicine. That's why I've quoted it here. And in 2018, ASHRAE guidelines also overwhelmingly recommended letrozole compared to clomiphene citrate. So it's a matter of using clomiphene citrate or letrozole. I wouldn't, but so far as academics is concerned, letrozole, practically I use letrozole only if clomiphene does not fare well. One. Secondly, now a recent study also has come up which in which you can increase the dose of letrozole from day 2 to 6. Normally we give it is then for 5 days, but it can be given for 7 days from day 2 to day 8, or even for 10 days from day 2 to day 11. So for up to if there is not adequate response, but if there are other factors for infertility, of course they have to be managed otherwise. Now, right. Conclusion में ये 5-6 points जो हैं, this is important. A common endocrine disorder affecting reproductive aged women. It is important to understand the diagnostic criteria to differentiate this condition from other similarly presenting diagnoses. Consequences associated with polycystic infertility, insulin resistance, dyslipidemia, metabolic syndrome, OSA, mood disorders, considered and appropriately screened. Management of PCOS includes combination of lifestyle modifications, and you know their importance now, and pharmacological treatments targeted towards specific symptoms. Combined hormonal contraceptive pill, first-line treatment for hirsutism and irregular menstrual cycle. Letrozole is the first-line treatment for ovulatory, oligo-ovulatory infertility associated with polycystic ovaries. Thank you. अब मैं तुम्हें थोड़ी देर के लिए एक दूसरी प्रेजेंटेशन भी दिखा दूं। ये मैं जल्दी से चलूंगा इसमें। ये चल रही है नहीं, ये क्यों नहीं आ रही? शेयर करें। अच्छा, अस्सलाम वालेकुम जी।
गुड मॉर्निंग सर।
हाँ जी, ये क्वेश्चन है, इज इनफर्टिलिटी एसोसिएटेड, क्या था जरा दिखाएं, दोबारा से निकल गया सवाल क्या था। Is infertility associated with PCO or delay in conceiving due to resistance, as we used to counsel patients that it might delay conceiving? There are multiple factors actually in polycystic ovarian syndrome. One, of course, is ovulatory dysfunction and the changes in the hormonal milieu. Essentially that, but insulin resistance has a complex mechanism, as I will briefly show you in this presentation. इसमें ये actually, these are two diagrams. Insulin resistance results in a compensatory hyperinsulinemia, which stimulates ovarian androgen production and ovaries in those ovaries which are genetically predisposed to that. And there is this pulsatility of gonadotropin releasing hormone, which favors production of LH compared to FSH. And that also acts on these granulosa and cells. And because of it is important to understand these two diagrams, which I'll put up for you to go through, and they'll help you understand how insulin resistance helps produce more of androgens in polycystic ovary women. That's about it. We'll address your questions in the next session. आज ये polycystic ovary syndrome का topic था, and we covered that in 55 minutes. आप क्या पढ़ाने लगे हैं सर?
सारे थैंक यू कर रहे हैं।
हाँ जी।